Good evening, ladies and gentlemen. I welcome you all to this month's Journal Club. So firstly, I would like to thank Dr. Sumit for actually ably guiding this Journal Clubs for the last 6 months. And over a period of time, we have been trying to increase the scope of the Journal Club. And as one of our endeavor, we have been trying to incorporate the myeloma specialists and the physicians from all the SAARC countries. As you would all see that one of the agreement for the SAARC was to increase the population and health related activities across these countries. And following the same guidelines, we have been trying to go ahead and work in concordance or along with these countries. So as part of it, we have 2 of our students who have been working in close association with various physicians across this country. In one, assessing the treatment accessibility, availability, and the healthcare cost across the SAARC countries, and wherein we have included all the myeloma physicians from the SAARC country to participate in this survey, which was done under the guidance of Dr. Pankaj. Second study, which was also done under Pankaj sir, was about the various clinical trials and the disparities of the research across the SAARC country, which again was done by one of our students. So today's Journal Club is going to be presented by a doctor from Nepal who is going to present this. And for moderating this particular session and for the Journal Club, I would now like to invite Das sir, Brigadier Satyaranjan Das sir, one of our executive committee member and the vice president of Image, to take on the stage and to take it on further. Over to Das sir, please.
Thank you, Uday, and good evening to everybody. Good morning, Dr. Saji. So today's Journal Club is really exciting when I know. And first, I want to thank Uday and Sumit for taking the image and making us learn new things. We stop reading now after retirement, so at least they are making us learn new things day by day. So today's Journal Club topic is about the risk stratification and high risk multiple myeloma, and we have Dr. From Nepal is Dr. Nirmala Shrestha. She will be presenting the Journal Club today. And as we know, in myeloma, risk stratification is very important. This has been changing for last maybe 2 decades. Initially we used to see only few the disease load, and subsequently some of the clinical features associated with bone marrow features. Then came the cytogenetics. Now it's genomics. So in this changing field, we need to learn new things, and Dr. Saji is there today to give us all the inputs about the change and why the need of the change and what is required that we have to stratify multiple myeloma, that whether it is a low risk, intermediate risk, or high risk. Now, without any delay, I will request Dr. Nirmala to start the Journal Club presentation, please.
Good evening, everyone. I am Dr. Shrestha. I'll be presenting today's Journal Club. It's on International Myeloma Society, International Myeloma Working Group Consensus Recommendations on the definition of high-risk multiple myeloma. We all know multiple myeloma is a plasma cell malignancy with a rising global burden. Over the years, therapeutic strategies have evolved significantly from traditional chemotherapy to modern regimens. Although survival rates have improved, finding a cure continues to be difficult. Survival outcomes in multiple myeloma are highly variable, ranging from a few months to over a decade. This variation arises from differences in clinical presentation and underlying biological features. Thus, refining risk stratification is critical to deliver risk-adapted therapy and improve outcomes, particularly in patients with poor prognosis. Risk stratification systems have evolved over time, from the Dury-Salmon system to the International Staging System, the revised International Staging System, and second revision. However, with newer therapies, these older models often prove inadequate. Since then, we have gained more insights from molecular and genomic profiling, leading to the development of even more refined stratification models and consensus guidelines. Presently, deletion of the short arm of chromosome 17, translocation 414, 1416, 1420, and chromosome 1 abnormalities such as gain or amplification, collectively referred to as 1q+, and deletion of the short arm of chromosome 1 are considered high-risk cytogenetic abnormalities. There are limitations of the current stratification. Even with advances, high-risk patients still face early disease progression and poor survival outcome, and about 62% of patients are classified as intermediate risk by revised international staging system, but their actual outcomes are vastly different in practice. High-risk multiple myeloma is inconsistently defined across studies and clinical practice. Factors contributing to this variability include marker selection, diverse testing platforms like FISH, NGS, gene expression profiling. Other factors include inconsistent thresholds and limited access to advanced diagnostics. Advances in molecular diagnostics, particularly NGS and gene expression profiling, have transformed risk assessment in hematological malignancies like AML and MDS. These tools are now increasingly being integrated into multiple myeloma risk models, allowing for deeper molecular risk assessments. To align these new tools with clinical care, the International Myeloma Society, along with the International Myeloma Working Group, conducted a workshop with a panel of experts. The goal was to create a data-driven, practical definition of high-risk multiple myeloma based on molecular and cytogenetic data, specify marker-specific assessment thresholds aimed at identifying the 20% of multiple myeloma patients with the poorest prognosis. The workshop had open discussion with presentations of both published and novel data. Every attendee could share data in real time for a robust consensus building process. Emphasis was given on prognostic impact of specific risk factors. Key data sets included were IFM, Harmony, Forte, GEM, German myeloma multicenter group, myeloma 11, Emory 1000, MMRF Compass, and Mayo Clinic cohorts. These were independently analyzed to assess prognostic features and address key questions on multiple myeloma risk rather than pooled for statistical analysis. Deletion of short arm of chromosome 17 is observed in around 10% of newly diagnosed patients, with prevalence rising up to 60% in relapsed or refractory multiple myeloma. It is associated with advanced disease and aggressive clinical presentation. Median overall survival is around 3 years at diagnosis, and at relapse, it drops to 18.1 months, with median progression-free survival at just 5.4 months. Importantly, prognosis worsens with increasing cancer clonal fraction of deletion of short arm of chromosome 17. Studies have evaluated cancer clonal fraction thresholds ranging from 1% to 60%. This Kaplan-Meier curve from GEM studies shows the impact of deletion of short arm of chromosome 17 cancer clonal fraction on survival outcomes. The figure A shows progression-free survival and B shows overall survival analysis with deletion of short arm of chromosome 17 distributed into 3 groups according to cancer clonal fraction cutoffs: less than 20%, 20 to 50%, and greater than 50%. The GEM and Harmony data sets show that patients with cancer clonal fraction less than 20% for deletion of short arm of chromosome 17 do not exhibit significantly worse outcomes, whereas those with greater than 20% experience marked reduction in progression-free survival and overall survival. While the strongest discriminatory power lies with cancer clonal fraction of 40 to 60%, the panel agreed a practical threshold of greater than 20%, assessed using CD138 purified cells for definition of high-risk multiple myeloma. TP53 is located on short arm of chromosome 17. Loss of this gene either by deletion or mutation leads to tumor suppressor dysfunction. Only about 1/3 of monoallelic deletion of short arm of chromosome 17 cases have TP53 mutation in the remaining TP53 allele. Biallelic inactivation, where one allele is deleted and the other mutated, represents the worst prognosis. Forte trial, COMPASS, IFM, Harmony, and GEM analysis all support that deletion of short arm of chromosome 17 and TP53 mutations alone or together are strong independent predictors of poor progression-free and overall survival. The Myeloma 11 trial demonstrated that biallelic TP53 inactivation results in a 3-fold increased risk for progression and a 5-fold increase in mortality. These results were corroborated by COMPASS and IFM studies as shown in this Kaplan-Meier curve C and D. Detection via NGS on CD138 cells is recommended for accuracy. Translocations involving immunoglobulin heavy chain locus, IGS, particularly translocations 1416, 1420, and 414 have long been considered high risk. However, newer evidence suggests these events may not confer poor prognosis even when occurring in isolation. Translocation 1416, seen in about 2 to 6% of newly diagnosed cases, was previously associated with poor prognosis. Recent IFM cohort analysis, however, show that when this abnormality is isolated, outcomes are similar to standard risk patients. Poorer survival is noted mainly when translocation 1416 co-occurs with deletion of short arm of chromosome 1 or gain or amplification of chromosome 1. However, 69% of patients with translocation 1416 also have gain or amplification of chromosome 1, while 22% shows deletion of short arm of chromosome 17 and 20% have deletion of short arm of chromosome 1. Importantly, when translocation 1416 occurs without a coexisting gain or amplification of short arm of chromosome amplification of chromosome 1, these patients often harbor other high-risk features like deletion of short arm of chromosome 17 or TP53 mutations. This pattern confirms that isolated translocation of 1416 is exceptionally rare in newly diagnosed multiple myeloma. Translocation 414 is present in about 10 to 12% of cases and is recognized as high risk in revised international staging system. Yet only 30 to 40% of these patients demonstrate truly high risk clinical behavior. Co-occurrence with gain or amplification of chromosome 1, which is around 55%, deletion of short arm of chromosome 1, which is around 11.3%, significantly worsens prognosis as shown in this Kaplan-Meier curve from the COMPASS MMRF dataset. GEM and Myeloma 11 studies confirm the same finding. Translocation 1420 occurs in about 2% of cases. It is particularly harmful when co-occurring with gain or amplification in chromosome 1 or deletion of short arm of chromosome 1. Data from COMPASS and Myeloma 11 show that these events tend to accumulate more risk markers over time, especially at relapse. Chromosome 1 changes are common in multiple myeloma. Deletion of short arm of chromosome 1 occurs in around 13%. Despite not recognized as high-risk factor previously, new data indicate deletion of short arm of chromosome to have adverse prognostic impact. Recent IFM cohort data show deletion of short arm of chromosome 1 significantly shortens progression-free survival and overall survival to 17 and 49 months respectively, as compared to 30 and 124 months in without deletion of short arm of chromosome 1. When biallelic, the effect is even more severe. Median progression-free survival drops to 9 months and overall survival to just 24 months from 19 and 60 months respectively. Deletion of short arm of chromosome 1 frequently co-occurs with gain or amplification of chromosome 1, which is as high as 55%. The MMRF COMPASS data confirm that biallelic deletion of short arm of chromosome 1 or monoallelic deletion with gain or amplification of chromosome 1 are linked to much worse survival than either lesion alone. SD6 genomic sequencing confirms the same findings. Gain or amplification of chromosome 1 in isolation by itself shows inconsistent prognostic value and is present in both standard and high-risk patients. The GEM cohort found no survival impact from isolated gain or amplification of chromosome 1. Evidence supports gain or amplification of chromosome 1 as a high-risk feature when considered in combination with other risk factors such as the translocation 414, 1416, and 1420 or monoallelic deletion of short arm of chromosome 1. Beta-2 microglobulin has traditionally been part of the international staging system. It may be elevated due to renal dysfunction or high tumor burden, making its prognostic role context dependent. Recent data from the COMPASS and FORTE trials show that beta-2 microglobulin greater than equals to 5.5 milligram per deciliter predicts poor survival in patients with normal renal function. When creatinine is less than 1.2 milligram per deciliter, high beta microglobulin likely reflects tumor burden, supporting beta-2 microglobulin as a surrogate high-risk marker. However, currently it is not feasible to identify those very rare cases with renal failure who might have truly increased beta-2 microglobulin without the influence of renal dysfunction. NGS has become standard of care in other hematological malignancies like AML and MDS. This consensus emphasizes use of NGS in multiple myeloma risk stratification. Even where full sequencing is not available, high-risk multiple myeloma definition can still be used with available elements. However, composite reporting of risk features should be avoided as it increases the complexity in data collection and interpretation. To promote consistent interpretation, the panel recommends using defined thresholds for cytogenic abnormalities and cancer clonal fraction, which should be above false positive rates for the assay. Also, analytical methods should be reported. It is important to distinguish risk stratification from molecular classification. High-risk multiple myeloma refers to aggressive clinical behavior, short survival, and early treatment resistance, therefore requires aggressive management, whereas molecular subtypes guide targeted therapy. For example, translocation 1114 is not high risk, but identifies patients likely to benefit from venetoclax. Emerging markers under investigation include gene expression profiles, circulating tumor cells, extramedullary disease, focal lesion burden. These are not yet included in this definition, but may be incorporated in future. Other potential high-risk markers include serum ferritin, BRAF, and MRC alterations, LDH, platelet count, translocation profiling, hyper-ApoBEC signature, and biallelic tumor suppression inactivation beyond TP53. These features requires further future exploration and validation. If the patient had high-risk multiple myeloma at diagnosis, they are generally considered high risk throughout. However, if not initially high risk, the panel considers the patient's risk at relapse or re-evaluation to be their risk status. Risk status must be reassessed at each relapse, as high-risk features can be accrued at relapse. This is the summary of consensus genomic staging of HRMM. The criteria for high-risk multiple myeloma are deletion of short arm of chromosome 17 and or TP53 mutation, translocation 414, 1416, or 1420 co-occurring with gain or amplification of chromosome 1 and or deletion of short arm of chromosome 1. Monoallelic deletion of short arm of chromosome 1 along with gain or amplification of chromosome 1 or biallelic deletion of short arm of chromosome 1. High beta-2 microglobulin greater than 5.5 milligram per deciliter with normal creatinine. Following our general considerations, NGS should be used for molecular studies. If FISH is performed, selected or enriched plasma cells with a 70% purity should be used. Bone marrow is the sample of choice, and risk assessment should be performed at diagnosis and at relapse. As you evaluate the progress made in stratifying risk in multiple myeloma, three major systems stands out: the revised international staging system, the second revision, and the more recent consensus genomic staging. The revised international staging system added cytogenic markers like deletion of short arm of chromosome 17, translocation 414, 1416 to the traditional international staging system alongside LDH. While it improved upon earlier systems, it also had limitations as described earlier. It classifies as approximately 62% of patients as intermediate risk with widely divergent outcomes. To address some of these gaps, the second revision incorporated gain or amplification of chromosome 1. However, it too has shortcomings. It excludes monoclonal antibody-based regimens and lacks data from industry-led trials. This leads us to the present system, a recent update in defining high-risk multiple myeloma. This model is based on genomic and molecular data and incorporates NGS-based markers, including TP53 mutation, deletion of short arm of chromosome 17, IGS translocation, and deletion of short arm of chromosome 1 and beta-2 microglobulin levels. Mayo stratification for myeloma and risk adapted therapy 4.0 has similar stratification criteria for high-risk myeloma. In addition, plasma cell S phase, primary plasma cell leukemia, and newly diagnosed myeloma with extramedullary disease are also included as high-risk criteria. Strength of this consensus is that it is evidence-based, evidences derived from real-world and clinical trial datasets. It had expert consensus developed by global myeloma leaders, ensuring clinical relevance. It aligns with modern therapies like triplet, quadruplet regimens, CAR T-cell, and bispecific antibodies. Limitation is that it recommends NGS-based assessments, which may not be available in low-resource settings. Even FISH-based testing faces challenges in low and middle-income countries. In many centers, FISH is outsourced, leading to delayed testing, sample degradation, testing on unsorted bone marrow aspirates, which drastically reduces sensitivity and leads to underdetection of key cytogenetic abnormalities. Normograms for beta microglobulin is not available for real-world settings. Threshold is derived primarily from Western cohorts. In conclusion, the consensus genomic staging of high-risk multiple myeloma should be used in clinical trials and integrated into routine multiple myeloma care. It may need to be revised in the future as new data emerge with new treatments and technologies. Thank you.
Thank you, Dr. Nirmal, for actually beautifully analyzing the paper. I am really grateful because I saw this paper, but I was just had a look at it, but you have nicely actually analyzed this paper. Yes, I fully agree. Going to the risk stratification, earlier we used to do FISH on unsorted bone marrow samples, which were very poor yield, and we never get a correct picture of that. And now I just wanted to ask Saji that when we do NGS on bone marrow samples, we are not doing it on sorted plasma cells. Saji sir, if you can just throw some light on this, sir.
Yeah, no, thank you. I just want to echo what you said. I think, Nirmal, that was a wonderful presentation and a good kind of analysis, dissection of what we wanted to do with the new IMS risk stratification system. So, I think it's just a second, just kind of looking at the whole concept of the effort, right? Why did we do that? It reflects two things. One is kind of the past in the sense that how much progress we have made in this disease, that the current treatments, many of those original risk factors that we considered as high risk are no longer carrying as much of risk as it did in the past, primarily because of the fact that treatments have improved and the impact has been quite a bit on all patient population, particularly the high-risk patient population as defined before, with the high rates of MRD negativity that we are getting. But at the same time, it is also forward-looking because it is telling us what the future of risk stratification in this disease is going to be, which is primarily genomic. And increasingly, it's going to be sequencing based because with the depth of the sequencing we can do right now, it is, we can get all the information that we can get from the FISH. And in addition, we can get some of the mutation data. So I think as the sequencing becomes cheaper and cheaper, it's definitely already cheaper than FISH in many of the settings. I think eventually that will be the de facto risk stratification tool that we use. The beta-2M, it's only a very small proportion of patients, maybe 2% of patients who get classified as high risk using the beta-2M criteria. So I think it's poised to be easily implementable in the future once we have the sequencing-based approaches more widely available. And I suspect that's probably going to be more widespread than even FISH because NGS is a technology we use across the board in all heme malignancies, and especially acute leukemias, AML being a good example of how we have managed to do that. So, going back to your question, Dr. Das, I think again the sorting. It's very important to do the sorting. What we have done in the past in our own lab has been using a immunoglobulin staining to identify the plasma cells instead of doing cell sorting in the past. But we have also shifted, and now we do a flow-based sorting for both FISH and of course for NGS as well. There are institutions that do magnetic bead suppression. I don't think it matters as much. One of the disadvantages sometimes with the magnetic bead is that the cells do tend to use CD138 over time as the sample ages.
And so definitely, because now in our country, the NGS what is available is not sorted NGS. That's the one of the problem, I think. FISH also, if you remember, few years back, we used to get the FISH done on the bone marrow sample, which are unsorted cells. After the sorted cells, we started getting good result in the bone marrow FISH, and we could stratify myeloma most of the time by the cytogenetics. But now, yes, we are doing now NGS for AML, ALL, even in lymphoma and all. So that's a good beginning, and the cost also is substantially affordable, so that we can do it for all the patients without any problem. But only thing is myeloma case, is there any study to say that if it is unsorted, we do NGS, we still get a good kind of, the threshold, and we can say, yes, whether this is, a high-risk myeloma or not a high-risk myeloma?
Yeah, no,
say I get, say, only 10%, 10% deletion, BAP is 10%, deletion 17. So what should I consider in that case?
Yeah, I know. So I think the sorting is going to be important. Otherwise, it becomes really challenging, especially when you're looking at the clonal fraction and so forth. So, so ideally, yes, I think we should sort them and do it. Now, for the deletion 17p, again, I think the more you have, the worse it is, right? So the question is, where does it make a sense for us to draw the line? And we said 20% make more sense because that was a little bit more conservative. And that might change too, right? In the future, many of these things are going to change, just like we had to use 2 abnormalities instead of 1 abnormalities because the treatments are so much better. I'm sure some of these clonal fractions for the acquired abnormalities are going to move upwards as the treatments get better too, because we always want to identify the 20 to 25% of the patients who don't do well with the current therapies. So I think that is the kind of the moving target. It's all relative, right? So if you classify 50% of the patients as high risk, it doesn't have the same value as if we classify maybe 20 or 25%, so that we can focus our attention on the patients who need the different approaches the most. And then the overarching goal of all this is, we want to identify patients uniformly across different trials, and we want to identify the patients who have the maximum need for newer therapies so that we can design clinical trials in a consistent fashion for this patient population.
Sir, one more thing, when we see extramedullary disease in the presentation itself, we know that this is a high-risk disease. Is there any, we are not sorting it out in this high-risk category, which are basically genomics, but is there any correlation to say that is the extramedullary disease will have more frequently such kind of, like we see sometimes an TP53 mutation and this thing, but is there a correlation that extramedullary disease obviously doesn't do well, whatever we do?
Yeah, no, I think it's a very important question. So I suspect, again, I don't have an actual percentage, but the vast majority of the patients with high risk clinical characteristics like circulating plasma cells, extramedullary disease, high proliferation rate, they tend to have genetic abnormalities also. So it's an overlapping group of patients. So I would say, just a guesstimate, I would say probably 60 to 70% of patients with those high risk clinical abnormalities will get classified as high risk based on the current genomic classification. One of the exceptions for the circulating plasma cells being the 1114, because those patients tend to have high numbers of circulating cells, even though they are not high risk. So with the exception of that, I think all the other groups of patients will get captured.
Sir, what about gene expression profile? Now though it is not available in India, but there are a lot of talk is going on, and earlier also this gene expression profile based, risk stratification was there. So we have got access to an NGS, but not GP. What is your assessment on that?
Yeah, no, it's a challenge. I think especially with the DNA-based testing, the sample stability is not that much of an issue because it remains stable and we are okay with it. With RNA expression, it's much more trickier, and I think the challenge has been implementing it in the clinical practice. So we have not really made much progress there. It does provide valuable prognostic information, but it'll be interesting to see with the revised risk stratification how much incremental value does gene expression bring into the picture over and above the current stratification system. Okay, Pankaj may have question.
I think any faculty wants to give some suggestion or some questions. Dr. Pankaj, please.
Yeah, thanks, Shazi, and thanks to the presenter. I really liked a very simplified way of presenting the Journal Club. So congratulations for that. So Shaji, we know that even there are high risk cytogenetic abnormalities, but still some patients behave as a standard risk, and some patients who we consider at standard risk but behave poorly. So with this new system of classification, what do you think? How many patients who are really high risk can be classified by the new classification system?
Yeah, no, I think Pankaj, that's a good question. I think again, none of these classification systems are ever going to be perfect because eventually the clinical behavior is probably going to be the most important thing. My guess would be, well, we would probably should have a kind of a CI somewhere around 0.8. So I would say probably about 80% of the patients are going to be correctly classified by the IMWG system. It's once you get to that 70 to 80%, it's much harder after that to improve upon the specificity of these tests just because biological variability, right? So it's really hard.
Okay. And my second question is, I see that the serum creatinine has been brought from 2 to 1.2. So I always, used to wonder when we consider as a CRAB features, it was the only the creatinine value, which was kind of a 2 instead of, it should have been 1.2. Somebody who has renal injury. So is it now in the CRAB criteria also you feel that the creatinine value will be brought from 2 to 1.2, or there it will remain as 2 only?
Yeah, so nothing is going to change with the myeloma definition. The reason why the 1.2 was we wanted to be absolutely sure that there is no renal reason for the beta 2M to go up. So taking that renal question completely out of the beta 2M was the reason the 1.2 was chosen. And again, it's kind of a continuum, right? I think the higher the number you do, less specific the beta 2 more than 5.5 is going to become.
Okay, and the last question is, even though, we say more than 5.5 is high risk, but in the original cohort, is there any kind of a cutoff of beta 2? Let's say, sometimes we say 20,000, 50,000. So is there above 5.5, is there anything which is, again, we say some cutoff, anything like that coming up?
No, I think the reason for the 5.5 was because one, of course, existing data and the existing acceptance of that being a high risk. So could 7 be higher risk than 5.5? Maybe. But once you get to that 5.5 and above, it's kind of hard to really kind of make multiple cut points. So the 5.5 is something number that everybody remembers. So there's not much value add to go from 5.5 to 6 or 6.5. It just doesn't, again, small proportion of patients, when you start cutting down into subgroups based on different cutoffs, it becomes even smaller. So there's no added value to doing that. So it's a little bit of a practical thing plus where the data is.
Right. Thank you.
Dr. Sumit wanted to ask some question. Dr. Sumit?
Hello, sir. Am I audible?
Yeah.
Yes.
So, sir, in continuation to Pankaj's first question, we occasionally come across patients who have standard risk cytogenetics and some high risk cytogenetics. So, for example, day before yesterday, I saw a patient with trisomies along with 414 and 1Q. So, in
Yes.
such a case, would trisomy override everything else, or will you still count it as a high risk myeloma as per current era?
Yeah, that's a good question. So, we did publish quite a while ago showing that trisomies in the presence of singular high-risk abnormalities does overcome some of the risk. Now, how much it overcomes is really in the presence of two abnormalities, it's not as much clear. But generally speaking, what we have seen across, like even when we looked at the 17p at that time, it did decrease the impact of 17p. So I suspect that is going to hold true even with the new high risk classification.
Any other question by the faculty?
I was just Hari here. Yeah. So I was just wondering, just like how, I mean, there's nothing like a dynamic high risk that is saying, for example, when we're talking about many of the hyperdiploid variants who behave badly, and we come across that only after seeing some sort of partial response or an induction failure to these patients. So is there some way is there going to be an allowance for doing something like a dynamic risk stratification that you put these patients into high risk, like how we would do for acute lymphatic leukemia patients when they move from a standard risk to a high risk when they do not achieve the responses to a standard therapy.
Right. So, Hari, I think it's important. I think so. We know that primary refractoriness is a high risk characteristic. So, I think all these the risk stratification is best used at baseline. After that, the clinical behavior should decide whether somebody is high risk. So, the lack of response is becoming harder, right? Because we're using quadruplets and triplets in these patients. It's less than 5% of patients are primary refractory. But what people have shown is, for example, if you don't get MRD negativity early on, you are much more likely to relapse early. So I think it may not be a partial response. So one could develop systems which says that if you are not MRD negative at the end of induction therapy, could you be considered as a higher risk category, which is what they did for the Midas trial, right? So that's what they did. If you didn't have MRD negativity at the injection, they were considered high risk, and then they were randomized to 1 versus 2 transplants. So I think the dynamic aspects are 2 elements. One is the depth of response achieved over a defined period of time, whether it be 6 months or 12 months. And the second would be how fast patients relapse. So I think we get multiple opportunities along the disease course to redefine risk based on the depth of response, rapidity of response, and the rapidity of relapse.
Yeah, thank you. Thanks.
There are 2 questions for Dr. Saji. Actually, Dr. Sanjeev has asked that does NGS is the recommended investigation of choice for risk stratification rather than myeloma FIS? I think we have already, to some extent, answered that yes, it will be required. If you can just add something.
It's going to be the future for sure. I mean, I don't think all the labs are equipped to do that yet, but having the definition out there hopefully will provide some added stimulus to make that change over the next decade.
So Dr. Amjad Jafar has asked, hello.
Dr. Shaji.
Sir, yes, sir, please go ahead.
Dr. Shaji, good evening. This is General Velu Naya here.
Yes.
So that was excellent, and I must congratulate Dr. Nirmal for an excellent presentation and Das for bringing out the relevant points and you having answered it. I have a very basic question. One is, about the remaining high risk through the course of the disease, and the others evolving to the higher risk depending on, what happens in terms of mutations. Now, are there any time points when the clinical behavior is stable that you will have to look at a high risk that he remains stable, or does he lose some of the high risk, mutational features along the various types of treatment that we are giving today? So when do you, if at all, repeat it, besides relapse and besides a deterioration in the clinical feature, the clinical behavior?
Right. So I think 2 things. One is, it kind of goes back to that conditional survival type thing, right? So if somebody is high risk and does very well over the first few years of let's say they get a 6-year PFS or a 10-year PFS from the first line therapy, are they truly high risk? I would say no. I think usually the behavior with the first line therapy, as long as that is a good regimen, usually defines the disease biology better than anything else. However, as Hari pointed out too, these are dynamic, right? Things keep changing. So somebody may have had a really good outcome with the first cycle or first regimen or the first and the second regimen, and then they develop a 17p deletion or a 1q amplification on top of what they had before. So any new genetic abnormality that shows up, which was not there at baseline, is often associated with a change in the clinical behavior towards more aggressive. Because I think 1 is the specific abnormality, and 2 is the fact that it's an unstable genome that allowed that abnormality to actually show up in the first place.
So it's the clinical behavior which will dictate further testing, by and large.
Yes. I think for sure, in the subsequent lines of therapy, generally, I think we should always get a panel for the secondary abnormalities like the 1p, 1q, and 17 at the time of relapse, a limited panel. I think which would be important for us to again predict. Somebody didn't have 17p but has that now at relapse, then we would anticipate that the patient is going to behave more aggressively.
Thank you.
Dr. Saji, one question is from Dr. Amjad Jafar, that in the era of MRD negativity being achieved by modern 4-drug regimen, how relevant is ASCT these days? I know you will answer it quickly.
I know it's always a controversial question, but I think it's, transplant is still an important element. So if you look at Perseus, 4-drug regimen gives you high MRD negativity, even higher after transplant, and an estimated PFS of 12 to 15 years. And that couldn't have happened without the transplant also being part of it, because you can compare it to what we're seeing from Cepheus or the other trials. So I think transplant still has an important role to play. It might change in the future that we might not do it as part of frontline therapy, but until we can cure myeloma, transplant is still going to be part of the mix.
Thank you, Dr. Saji, for being nicely answering and making us wise on myeloma. So now we'll go to the next. It is the journal club discussion. the declaration of the results of the Eagle Eye. I'll request Dr. Sumit to start it.
Hello, sir. Is my screen visible?
Yeah.
Okay. Good evening, everyone, and thank you for the nice discussion. So for July 2025, this month, the Journal Scan article was CD56 expression predicts response to daratumumab-based regimens, published last year from Ohio State University in USA. So just to brief the process, a recently published article is chosen. We invite a commentary of 175 words from anyone, irrespective of designation, before a deadline, and the best commentary selected by a team of blinded reviewers. Whosoever wins gets a chance to present the Journal Scan along with a certificate, along with some credit hours and image lifetime membership. Purpose is that all the young faculties as well as residents should read the latest articles, learn the art of critical appraisal, refine the art of scanning. This will promote more letters to editors from our country. One of our professors said that the more you read, the more you will write. And as Dr. Das has said, the more you write, the more you will become. So the more we read, the better we are. So a special mention before announcing the name of the winner is for Dr. John Ibrahim from CMC Ludhiana. He is a young faculty in CMC Ludhiana and he presented a journal club last month. It was actually tiebreaker between him and the winner. And it took me another reviewer to announce the name of the winner. So this month's winner is Dr. Meghna Yadav. She's a senior resident from AIIMS New Delhi. So congratulations to you, Meghna. And I request Nirav to play the recorded commentary.
Good evening, respected teachers, mentors, and colleagues. I would thank the Image Group for giving me such a wonderful opportunity. I will be critically appraising a recent translational study published in Blood Cancer Journal on 12th April 2024, exploring CD56 expression as a predictive biomarker for daratumumab efficiency in multiple myeloma. Although anti-CD38 monoclonal antibodies such as daratumumab have significantly improved outcomes in multiple myeloma, they do not produce uniform responses across patients. CD38 expression level, while essential, do not fully explain this variability. CD56 or NCAM1 is evidently expressed in more than 70% of myeloma cases, but its role as it has been traditionally limited to immunophenotyping. Importantly, prior work by this group revealed that CD56 activates the RSK2-CRAB1 pathway that modulates the MCL1 and CRBN, two proteins involved in myeloma cell survival and treatment resistance. These insights prompted the hypothesis that CD56 might serve as a functional predictor of therapeutic response, especially in combination regimes involving immunomodulatory agents. The study aimed to investigate whether CD56 expression could stratify patients for improved responses to DARA using both clinical data and mechanistic in vitro validation. Authors showed that CD50 used the retrospective study, single center, analyzing 152 myeloma patients treated with DARA, exploring whether CD56 expression predicts treatment responses, particularly in combination with immunomodulatory drugs. The study also includes functional experiments to support its mechanistic claims. Authors showed that CD56 expression enhances progression-free survival under DARA immunomodulatory regimes supported by biological modulation and immunological effects. And there was no significant overall survival differences, but CD56 overexpression enhanced the antibody-dependent cellular cytotoxicity and immune checkpoint signatures. Effect was more pronounced using combination of daratumumab and immunomodulatory drugs rather than using DARA alone or with proteasome inhibitors. Here, panel E to G illustrates the predictive value of CD56 expression in multiple myeloma patients treated with DARA. Panel E bar graph demonstrates that patients with high CD56 expression achieved a significantly high rate of deeper response, that is complete response or very good partial response, compared to CD56 low patients. In panel F, this translated into longer progression-free survival across all DARA regimes. The Kaplan-Meier survival curve shows progression-free survival on y-axis, and the patients were divided by CD56 expression with low CD56 in blue line and high CD56 in pink. CD56 high patient experienced a statistically statistically significant improvement in progression-free survival under daratumumab therapy. This supports CD56 as a marker of treatment durability, not just response rate. Most notably, panel G showed that the survival advantage is especially apparent when daratumumab is combined with immunomodulatory drugs like lenalidomide or pomalidomide. These findings collectively support CD56 as a promising predictive biomarker for daratumumab-based therapies. The study exemplifies the translational research by combining retrospective clinical data with functional cellular assays to uncover a biological, plausible, and therapeutically relevant biomarker. One of the key strengths is the novel identification of CD56 as a predictive marker, and they used complementary approaches, that is both clinical and mechanistic, which supports the biological possibility of their finding. Importantly, they control for major confounders in their statistical models. However, the limitation being the retrospective design and single center data limits the generalizability. The 10% cutoff for CD56 lacks biological validation. Sample size is modest, particularly for the isatuximab treated subgroups, and no overall survival advantage was observed. Moreover, CD56 was assessed prior to therapy, not at initiation, which could affect the reliability. This study raises the possibility that CD56 is more of a disease phenotype marker than a true predictive biomarker. While progression-free survival is improved, we must interpret these findings as hypothesis generating. They offer promise, but not the immediate practice-changing goals. To improve upon this, we need prospective studies using validated thresholds across diverse population. Functional in vivo modeling will clarify CD56 causal role. Integrating CD56 with cytogenetics and immune profiles could advance precision therapy in selection myeloma. In summary, the study offers compelling insight into CD56 as a predictive biomarker. Through further prospective studies are required to establish the clinical applicability. This is a strong translational study with meaningful implications, but methodological limitations tempers its immediate clinical impact. Thank you.
Thank you, Dr. Meghna, for presenting a study which has translational research and it has some clinical relevance too. So I would like to thank our reviewers, Dr. Tribikram Panda from Odisha, Dr. Das sir from New Delhi, and Dr. Hari Menon sir from Bangalore. So just to announce, for the next month, we will have Best of ASCO and Best of EHA 2025 with respect to the plasma cell dyscrasias on 28th of August 2025. And we have two young and bright faculty from India, Dr. Aditya Jandial from PGI Chandigarh and Dr. Nikhil Kumar from Fortis Delhi, who will do this honors. Kindly note that we will not have the journal scan for next month. And now moving on to the quiz. So control your adrenaline, hold your nerves and go on for the quiz. And if your initial few questions are wrong, don't worry. If Rishabh Pant can make a comeback after a broken foot yesterday and play today, I'm sure everybody else can make up. Thank you.
Thanks, Sumit. So let's go ahead with the quiz for the day. Just give me a second. So I'd request all of you, all the people who are listening today, to kindly join using this join code or by scanning the QR. There is no embargo on who all joins. Starting from full professors to MBBS students, anybody can join. And today we are just going to discuss 6 questions about what has been presented by Dr. Nirmal and what has been discussed by Dr. Shaji in detail. So it's just going to be a take-home messages or a review of what all has been spoken till now. I'm yet to see people joining. Okay. The panelists can also join, please. we'll wait for another 60 seconds before we start the quiz. We are just going to have 6 questions today, 20 seconds each. And everything has been discussed till now, whatever we are going to have it. And to present the quiz, we are going to have a youngster, a final MBBS student who has prepared the quiz question so you can understand how easy it is going to be. So without further ado, I would like to hand over the stage to medical cadet Rupika, who has actually worked on few of the SARC-based studies. So she will be conducting the quiz and I will be explaining the answers. But more importantly, anybody can still join because it really doesn't matter if you miss on one odd question. So you can just go ahead and join the quiz at any point of time. And it's going to be a real fun. So over to Dr. Rupika, please.
Very good evening to one and all. I am Medical Cadet Rupika, here to help Dr. Uday conducting this short but simple quiz. Starting with a question that's been already discussed in this session. What is the threshold for deletion 17p to be labeled as high risk? More than equal to 10%, more than equal to 20%, more than equal to 30%, or more than or equal to 40%?
You not only have to be correct, but it's the fastest finger first. Excellent. So I think Dr. Nirmal Shrestha explained it quite well. The threshold is 20% as per the latest consensus guidelines, but he has very beautifully answered. So we have Dr. Arjun leading the score with a tiebreaker with Kumar Animesh. Wonderful. So Dr. Nirmal had shown these two graphs and he has shown clearly that the strongest predictive value from this article is above 40 to 60%, but the consensus threshold for high-risk myeloma in CD138 purified cells is 20%. So for labeling a patient having deletion 17p positive or what we call a CCF, the cutoff is more than or equal to 20% in purified cells. So over to the next question.
What is the difference between MSMART 3.0 and MSMART 4.0 guidelines?
Excellent. So as most of you have answered it correct, so all these are different. So we'll just take it in the next slide to understand what is the difference between MSMART 3.0 and MSMART 4.0. Okay, we have a change in the leaderboard. So this is MSMART 3 and MSMART 4. So as you would see that previously what were labeled as 414, 1416 and 1420 have been taken out, and they say that in isolation they won't matter, but it is in combination with gain or amplification 1q or deletion 1p is what actually matters. Second, they also have mentioned that presence of biallelic deletion 1p has got a role to play. And lastly, they have said that gain or amplification of 1q plus deletion 1p actually has got much more important prognostic significance. So these are the differences between MSMART 3 and MSMART 4. And MSMART 4 is more or less in alignment with what is the latest IMS by IMWG consensus guidelines. So let's get on with the next question.
Which cytogenic abnormality is most strongly associated with double hit high-risk multiple myeloma? Translocation 1114, translocation 414, deletion 17p, or hyperdiploidy?
So again, most of you have got it right. So it is deletion 17p, which is the one which is higher, strongly associated with the high risk features. So as you would see here, So it's clearly mentioned that if you look at the footnotes, deletion 17p threshold more than 20% really has a important factor. All the other options that were given are not sitting in the high-risk myeloma. Only translocation 14-16 was there. But as you would see in the latest classification, in isolation, translocation 14-16 really does not matter. So let's get ready with the next question.
According to recent consensus guidelines, which combination of cytogenic abnormality most reliably predicts high-risk disease? Translocation 414 alone, monoallelic deletion 1p plus 1q gainer amplification, translocation 1114 with hyperdiploidy, or none of the above?
So I would consider this as a true success to the Journal Club. So people are getting it absolutely right. So it is a combination of deletion 1p plus 1q, which has got the highest predictive value. So we have Dr. Pratibha on the top, followed by Dr. Aditya. So this was presented again by the presenter today, that in combination of just 1q in itself really does not matter. So what matters is if you have a combination of 1q along with a deletion 1p or with one of these abnormalities, translocations, which are IGH mutated, so that makes more of a sense rather than having 1q in isolation. So it's one of the strongest predictor for a high risk. Let's get ready with the last question, second last or last, fifth question.
Which gene expression profiling signature is most acceptable stratifying high-risk multiple myeloma patients?
Okay, so this was one of those tough ones which was not discussed today. So we have got different scoring systems here, and these are all the various gene expression profilings. So the correct answer is Sky92. Oncotype DX is for the breast carcinoma. 21 gene recurrence score is nothing but Oncotype DX. So that's the other name for it. So that's also for the breast carcinoma. And 40 GEP is for melanoma. So this was slightly a googly for the hematologists. So all those oncologists who are on board can get it right. But for the hematologist, it's just Sky92. But Sky92 was definitely mentioned by Dr. Nirmal in his slides. Okay, so we have Aditya, though a hematologist, getting the right answer. Excellent, Aditya. So this was the original study which initially for the first time spoke about Sky along with RISS, and they have classified the patients and they have shown that Sky gene expression profiling can really matter when combined with RISS scoring. So getting to the last question.
Which biomarker is emerging as an independent predictor of poor outcome in modern era of quadruplet therapy? LDH, circulating tumor cell percentage, SUV tumor load on PET or CT, or age over 75?
Okay, so 87% of you are right. I'm not happy for 87%, but I'm actually sad for 7% of people who answered still LDH or SUV tumor load. So the correct answer is CTC percentage. Now, there is clear data to suggest. So Aditya, heartiest congratulations. And the most difficult question was GP signatures. So that was the one which was not answered by many, but heartiest congratulations, Aditya. But let's quickly go on to the CTC percentages. So people have clearly shown that CTC percentages does make a huge difference in overall survival as well as the progression-free survival. And in fact, now the cutoffs of 0.0001 is what is considered. Previously, it was more than or less than 0.0002. Now it's 0.0001, which is considered, and that's considered as one of the future markers in the latest consensus guidelines. So with this, we come to the end of the quiz for the day. And heartiest congratulations to the winner and rest all who have participated. It's more of a fun event rather than trying to judge who is the best out of all. It's primarily to make sure that all of you take home the correct message from the Journal Club, which is being carried on. So thank you all, and thanks Rupika for hosting the quiz. So over to Sumit.
Thank you, sir, for the nice and interesting quiz. I would request Dr. Das sir to convey the vote of thanks.
Thank you, Sumit and Uday for actually, leading these, image programs. I want to thank Dr. Saji for taking his precious time out and giving us all the, important messages and learning points in our day-to-day practice. Thank you, Dr. Saji. Thank you for being there and giving us all the directions. And I'll thank all the faculty who have attended this and the others, those who are there and attending and learning about myeloma. It's a great learning. Thank you, everybody.
Thank you. Thank you. Thank you, Shaji.
Thank you,
Very
sir.
nice
Thank
to
you,
see
sir.
you.
Thank you.
everybody.
Thank you. Thank
you,
you.
everybody.
Thank you.
Bye.
Thank you.